have new student again? Assalamualaikum.
Waalaikumsalam warahmatullahi. What, Doctor?
Who's Amir Omar? This is new student, Amir?
No.
Who's Amir Omar?
I don't know.
Amir is nice name, but who are you? Can I know?
I think, is this
Amir Omar.
Otto?
Just the name attracts me. That's why I'm asking. Who's this name? Who's this one?
Otto maybe.
Is it Otto?
Oh?
Otto bin Omar.
Yes, because his name is Otraya bin Omar. So probably using.
Who again? I didn't hear.
I think this is Otto, Doctor.
Otto?
Yes.
Okay. Otto? Who's Otto? Otto. Amir. Okay, maybe he like Amir. Okay, Amir. Okay, Omar. Can? Oh, still not come yet. Hatun still not yet coming, right? Is she most of the time absent from the classes or what?
Who, Doctor?
Hatun.
No, sometimes only.
Sleep.
But she will always a little bit late.
She late in the class, she late online.
I'm here, doctor.
Oh, her. Okay, good. I was thinking, okay. Good, you're here.
Kamu
Okay, so
bilang.
now, can we start?
Yeah.
How was your quiz, by the way?
So.
Okay.
Why none of you say, wow, it was nice, it was great.
Amazing.
Yes, Doctor.
Amazing.
Why we cannot have these answers from you?
Modesty, Doctor.
How was your Raya?
Wow, so great.
No, it's great.
You get money?
Sabah great.
Yes, I
How much you get money?
A lot.
Doctor.
Okay, you should share with us, please. We are poor here. Give us some money. Nobody
already finished.
Finish.
The greatest raya, Doctor. The best raya.
You should keep for your lecturer after Raya. We should buy gift for Dr. Baki. So, what is the student? Who are you? Oh my God. Zero for all. Okay. So, for this course, we will start with the reproductive system. So, in my part, we'll teach you, of course, the anatomy of the pelvic, the pelvic floor, the perineum. Then we will start with the male reproductive system, then the female, then finally we'll end with the anatomy of the breast. Actually, logically, breast should be not involved in this course because anatomically it's totally not related, but functionally related. That's why we include the breast in this course. Otherwise, anatomically, it's in the pectoral region breast. It's not related to the reproductive. That's why sometimes we, as the integrated system for anatomy, it's totally unfair because they miss a lot of organs together. We not follow the regions, we follow the function by the integrated. Anyway, this is our topic that we will study or teach during this course. So for today, we will start with the pelvic. We have 2 lectures, by the way. Okay, let's start. Where is my... Oh, not this one. Sorry. Mistake. Where is my lecture? Oh, here. Okay. Do you have any idea about the component of the pelvic girdle or the skeleton of the pelvis?
Yes, Doctor.
What is it?
Pelvic bone.
Yes, sacrum, coccyx. We have like the
Sacrum and
coccyx.
coccyx.
Yes, pelvic bone. We
Hmm.
have like pubic bone. We have like
Ischium.
yes, ischium.
Skim
We have
The
like
and ilium.
ramus,
yes. Okay. Good. Okay. Let me see just who's still coming. Nakib. Okay. Nakib. Okay. Okay. So you start first of all the bones that forming the pelvic skeleton, or we call it the pelvic girdle. It is like the ring-like bony structures. We know all that located in the lower part of the trunk. Consists of three parts, which is the hip bones. We have two hip bones, or we call it pelvic bones, and sacrum, and finally we have what? The coccyx. So we have to go in details for each part of the bony pelvis. So the hip bones, we know we have how many? Two, the right and the left side. They are regularly shaped bone, forming the part of this, the bony pelvis, and also attach the axial skeleton to the lower limbs. The main component or the articulation for the hip bones, we have three articulations. First of all, sacroiliac joint, pubic symphysis, and also what? The hip joint. Of course, the sacroiliac, from the name you have to know, means the articulation with the hip bone, with the ilium, actually, the part of the hip bone, which is the ilium, articulated with the sacrum. That's why we call it sacroiliac joint. Pubic symphysis between what? The bodies of the pubic. This part we call it pubic symphysis. And also the hip joint, which is the articulation with the head of the femur. So we have three articulations of the hip bones. The parts of the hip bones, I think you already been taken, I think in the lower limb, right? We study, but we just will go as quick revision in this part, because I know we still remember you take with Dr. Khaled last year, and also we also have this revision during the locomotor, right?
yes, doctor.
Yes, doctor.
So this would be just like revision we have to go through, because it's involved in the pelvic, not as a lower limb, as pelvic. So the parts of the forming the hip bone, we have three, which is the ilium, pubic, and the what? The ischium. These, before the puberty, they are what? There is a cartilage separate between these three parts. We call it what? Tracheate cartilage. The only fusion at the age of the 17 years old. These three parts, they forming what? The fossa, or the socket, a cup-shaped socket. We call it the acetabulum, that where the head of the femur what articulates to form what? The hip joint. So we start in details for each part of the hip bone. The first part, which is the ilium, the widest and the largest part among the three parts of the hip bone, located superiorly. The body of the ilium forming what? Superior part of the here, the superior part of the acetabulum. And below, above this acetabulum, we have what? We find the ilium become what? Expand to form what? The wing of the ilium, or we call it the ala of the ilium. So this wing, we have look from two surfaces, inner and the external surface. This one, it is the external, or this is from the lateral view. Here, this is the internal surface of the wing of the ilium. So the inner surface, when you define or you explain the shape or the characteristic, it is concave shape, forming what? The iliac fossa, which is the origin of the what? Iliacus muscle. If you still remember the iliacus muscle. What was the function of the iliacus muscle?
Retract the hip.
The hip or the thigh? Iliacus muscle.
Hip.
Okay. For the external surface, or we call it what? The gluteal surface. Here, this part from the name means it is the site for the attachment to the gluteal muscles. That's why we call it gluteal surface. The superior margin here, the superior margin of the wing of the ilium become what? More thick, forming the iliac crest. This iliac crest extend from the anterior superior iliac spine to the posterior what? Superior iliac spine. Below this, the posterior aspect of the ilium, we have what? Groove or indentation, we call it what? The greater sciatic notch. What is important to know this one? The anterior iliac spine, to measure what? The true length of the leg. We measure it, especially for the orthopedic, they measure it from the anterior superior iliac spine to the middle malleolus at the ankle what? Joint. This is the true length or the correct measurements of the leg length. But the apparent that we use for to measure the length of the leg, we use it from the umbilicus to the what? Middle malleolus. This is the apparent when we do for your clothes, pants, skirt. But for the orthopedic and surgeon, no, should be measured correctly from the anterior superior iliac spine to the middle malleolus. How to know anterior superior iliac spine? Of course, you will not do surgery. How to measure it? How do you know the surface anatomy of the anterior superior iliac spine? You know the inguinal ligament? So at the midpoint of the inguinal ligament here, this is the anterior what? Superior iliac spine. Clear? Okay. So the second part of the hip bone, we have what? The pubis. This is located anterior or located in the most anterior portion of the hip bone. Consists of the pubic body. Okay, that one located medially and articulate with the opposite pubic body at the what? Pubic symphysis. The superior part of the pubic body become more rounded and thick, very thick. We call it what? Pubic crest. This crest will extend laterally, forming what? The pubic tubercle here. This one. This is a projection from the pubic what? Crest. Later also we have the superior pubic ramus and what? Inferior pubic ramus. This
Doctor,
Doctor.
Yes.
the slide didn't move. It's
Yes.
still in the clinical relevance. Oh, okay.
Move now or not?
Yes. Move.
Yes, it changed.
Yeah, because maybe your internet is a little bit slow. That's why you receive it maybe late. Okay, I will try to go slowly, not too fast. Okay. So the superior here, as you notice from the X-ray, we have the superior pubic ramus and the inferior pubic ramus. They extend laterally from the body to form what? The part of the acetabulum, which is the superior, while the inferior will be what? Project toward the ischium. Here, this is the ischium. Both of these, superior and the inferior, they will forming or in part of the what? Obturator foramen. You know the obturator foramen? It is along the passage of the obturator nerve, obturator artery, and what? Obturator nerve that supply the lower limb. Okay. So the last part of the hip bone, we have the ischium. Okay. This ischium forming the posterior what? Inferior part of the hip bone. Consists also of the body, have inferior ramus and the superior what? Ramus. The inferior one will combine with the pubic, inferior pubic ramus, and forming what? SQ pubic ramus will this part have what? Enclose of the obturator what? Foramen. From here, the posterior aspect, from the posterior inferior aspect of the ischium, they will forming what? The ischial what? Tuberosities, of course, at the right and the left. Okay. These ischial tuberosities, this is where all the body weight falls when we are what? In the sitting position. When we sit in the right position, 90 degree, we should sit on the ischial tuberosities. Okay. So near the junction of the superior ramus and the body, there is what? Posterior-medial projection of the bone here. This one, we call it what? The ischial spine. This spine will be important later when we do measurement for the outlet, the inlet of the pelvis. The ligaments, the most important ligaments that attach to the ischium, we have two ligaments, which is the sacrospinous ligament and the sacrotuberous ligament. This one also we have in the museum when you go for the practical. I don't know how we will do the practical now. Did they close now the university? Totally close?
I think, I don't know.
For 4 weeks.
For 4 weeks.
Except for the student that need to, the postgraduate student need to do the experiments.
I think I can go there and maybe do picture for you and send it, because this one is very important. We can show the ligaments, because sometimes in the exam for the last year, when I point in the OSP, they didn't know these ligaments. Anyway, okay. So the sacrospinous ligament here connects between the ischial spine to the sacrum here, this one, the transverse ligament. This ligament will create what? The greater what? Sciatic foramen. Here from this foramen, they will allow the passage of all the nerves and the blood vessels to the lower limb. While the sacrotuberous ligament here, the longitudinal, they will run from the sacrum to the ischial tuberosity. Here, this is the ischial tuberosity. And they will forming what? The lesser what? Sciatic foramen. These ligaments are very important. The most important here that we have to know about the fractures in the pelvic, especially in the pubic or the ischium. In the pubic, mostly when there is fracture there, consider as the low injuries, because sometimes this type of the injury will become, or the fracture is stable, because they are surrounded by the muscles and the ligaments that allow help to stabilize the bone in its position. That's why we don't need any surgery, just rest and avoid like heavy movement or very risky movements. This type of the fracture can be seen in the osteoporotic patients who have already weakness in the bone. We can find what they have pubic rami fractures. Even sometimes they don't know they have fractures. By X-ray, accidentally, we can find the fractures. But the high energy injuries, this one will cause direct trauma or high risk to the soft tissue and the vascular, or cause vascular injury. Why this is very dangerous? Because it is unstable injuries, and the bones or the fractures, they may be damage the visceral organs, especially the bladder, the urethra, which will be the high risk of the damage. And there is fracture in especially at the part of the hip bone, acetabulum, that involved with the head of the femur. And of course, because this area is highly vascular, maybe cause life-threatening by hemorrhage. The patient might die because of the bleeding, severe bleeding. Okay, Of course, this type of the fractures need what? Urgent surgery. Okay? Especially that include the fracture, the acetabulum and the sacroiliac what? Joint. So the second part of the pelvic girdle, we finished the hip bone, the ilium, pubic, and the ischium. Now we go to the sacrum.
Doctor,
Yes,
I think the slide.
not move.
Yes.
Okay. Ready? We have to wait or what? Should we go to the Zoom? You want Zoom or what? I don't know what's the problem today. You have it? Okay.
Not yet. I don't know if it's only me, but how about others?
The rest, they have the picture or not?
Oh yeah, it's not only me, doctor.
No, doctor.
No.
We can
Try re-upload, doctor. The
Do you want to go to the Zoom or you want to stay with the Google?
I prefer Zoom, doctor.
What?
I prefer Zoom.
You prefer Zoom.
Yeah.
Okay.
Zoom is fine.
Okay. The problem is the time, but okay, no problem. Okay, I will end this one. We'll go to the Zoom. Okay.
Okay, doctor.
Okay. Okay. All of you get the screen?
Yes, doctor.
Yes, doctor.
yes, doctor.
Good. Okay. Oh, by the way, I have a nice background. Welcome my kitchen. Yeah, I don't have office table. That's the disadvantage when you work from home. I don't have office table. Only I use what is it? The kitchen for cooking. Anyway, okay. Where we reach? Sacrum. Okay, so this is the second part of the pelvic, of the pelvis, which is the sacrum. Forming the sacrum is the terminal part of the vertebral canal, forms the posterior aspect of the pelvis. It is thick and help in supporting and transmitting the weight of the body. So as you know, the sacrum is formed by the fusion of how many vertebra? 5 sacral vertebra. But how many nerves we have? The sacral, how many sacral nerves?
We have activated nerve.
No, not the branch. How many? How many the number of the sacral nerve? 4 or 5?
4.
5.
4
Five.
are
5.
fusion of 5, but the nerves are 4. S1, S2, S3, and S4. Okay, so the sacrum, it is inverted triangular
Triangle.
shape, consists of the base. This is the base of the sacrum and the apex, and have 4 surfaces. The base, articulate with the 5th lumbar vertebra, while the apex is connected or attached with the coccyx. The surfaces that we have in the sacrum, it is the auricular surface, here this one, the lateral, located laterally on the sacrum, shaped like the outer ear. This auricular surface articulates with the ilium, forming the sacroiliac joint. The anterior and the posterior surface, they attach to the pelvic ligament and the pelvic muscles that we're going to take it later. Internally, we have the sacrum. There is internal canal here of the vertebral column, which is continuation with the core, along the core of the sacrum, and end at the fourth sacral foramina. Here, this is the fourth sacral foramina as the sacral hiatus. Okay. The dorsal surface of the sacrum, now we have to know the characteristics of each surface, the dorsal and the pelvic surface. So the dorsal surface of the sacrum, it is, or we call it the posterior, it is coarse and rigid area. They have median sacral crest, here this one. This is formed by the fusion of the spinous process of the first three sacral vertebrae. And they give attachment to the supraspinous ligament. Same like the covering of the same vertebral column or the other vertebral column. For the intermediate, beside the median sacral crest, we have the intermediate sacral crest, which is formed by the fusion of the sacral articular processes. Here, this is the intermediate, this one. Okay. The posterior sacroiliac ligament will attach to this crest. While the lateral sacral crest here, this one, at the both sides, this is formed by the fusion of the transverse process of the 5 sacral bones. The lateral sacral crest offer attachment to the posterior sacroiliac ligament and also sacrotuberous ligament. Here, this is the sacroiliac and sacrotuberous ligament. While the pelvic surface, or we call it the inner surface of the sacrum, is totally different from the dorsal. It is less remarkable, and in the adult have how many lines? 4 transverse lines, which represent the remnant of the fused sacral intervertebral discs. Superiorly, they will have there is anterior projection. We call it sacral promontory, while the posterior they will forming this sacral promontory will be one of the boundaries or the posterior borders of the pelvic inlet. Later, we will have to understand what's the meaning of the pelvic inlet and the pelvic outlet. So the muscular attachment with the sacrum, we have 3 muscles that attach to the anterior surface, which is the piriformis muscle, one of the muscles of related to the lower limb, and also the coccygeus, one of the muscles of the pelvic floor. And finally, we have the iliacus, also that is related to the movement of the thigh or the lower limb. For the posterior surface, we have also 2 muscles that attach to the sacrum. It is the multifidus lumborium, help to stabilize the spine. And also we have the erector spinae. This will help for extension and the lateral bending of the head and the vertebral column. All these 2 muscles attach to the posterior, while these 3 muscles attach to the anterior surface, or we call it the pelvic surface of the sacrum. The last part of the pelvic girdle, we have the coccyx, which is, we call it the tailbone, and it is the terminal part of the vertebral column, composed of how many vertebrae? 4 vertebrae. They fuse together to produce this triangular shape. Embryologically, if you still remember the embryology, it is actually considered as the skeletal remnant of the caudal eminence. Still remember caudal eminence of the spinal cord? This caudal eminence presents in the week 4 until week 8 of the gestation. This eminence will be regress gradually and only will be remain as the coccyx. This only the bony projections. Okay. Initially, before or during the development, the coccygeal vertebrae are separated, but throughout their life, they will fuse together, forming this triangular or one continuous bone. As the structure of the coccyx also consists of the apex, base, anterior, and posterior surface, and has two lateral surfaces. The base of the coccyx located more superiorly and attached or articulate with the sacrum, while the apex situated more inferiorly, which is at the terminus of the vertebral column, and the lateral surface of the coccyx will be marked by the small transverse process that only project from the coccygeus number 1. The rest are very not remarkable. The coccygeal cornea here of the first coccyx vertebra, this is the largest of the other small articular process of the coccygeal vertebra, and they project, as you notice, upward. For what? To articulate with the sacral cornea. So the coccyx, as you know, articulate with the sacrum, forming sacrococcygeal symphysis. There is vertebra or the cartilage joint connects between the coccyx and the sacrum. The movement, of course, here it is very, very limited, minor flexion and extension. This only happens during the defecation or the labor. The function of the coccyx, of course, it's very important and play important role. Give a lot of the point of attachment for various structures. First of all, to the gluteus maximus muscle and to the elevator ani muscle, one of the main muscles that forming the pelvic floor, and also the anococcygeal raphe. This one, it is a fibrous ligament starts from the coccyx and support the position of the anus. Okay, this one, anococcygeal raphe here. You see how it's connected to the coccyx? Help to remain the position of the anus at the center. The coccydynia, what is the coccydynia? This is caused by there is a pain in the coccyx. Happens when there is when you sit on the tip of when you sit on the coccyx. Actually, as I said, the normal position, you should sit on which part? The scale tuberosities, right? This bone, we should sit.
Yes, the scale tuberosity.
If you sit abnormal or the wrong position, you will cause pressure on the coccyx, which will lead to known as the coccydynia and pain. That's why after long time wrong position, you will feel pain at the back, because you sit on the coccyx, because inflammation, pressure to the coccyx. Of course, most of the causes for the coccydynia, it's prolonged sitting for the unbalanced or sometimes cycling, or of course the wrong position. And the second reason for this coccydynia, it is during the childbirth, because we know the childbirth causes stretching of the pelvic floor muscles during the labor. Because of this pressure, they will cause pain to the coccyx. Severe pain, of course, during the childbirth or the delivery or the labor. Severe pain and cause pain in the coccyx. You feel like it will be separate. Somebody when you want to twist your arm, this pain, like you feel like it will almost be fractured. Okay. So for treatment for the coccydynia, of course, we give rest, anti-inflammatory medication, and of course the painkiller to relieve for the symptoms, sitting in the pillow, cushions, and of course to support what the potic. Treatment, the patient who have persistent coccydynia, we give them what? Local cortisone injection. Of course, physical therapy with the exercise will help for the patient recovery, and of course, at the last option we do it is by surgery, by removing what? The irritated bony prominence, but we very rare we do surgery for the coccydynia. Mostly just the painkiller, anti-inflammatory. If it is like we give cortisone injection. This will be all helpful. We never reach to do surgery for coccydynia. Okay, we finish the part of the pelvic girdle. Now we go to the pelvis. Okay, we already talked about the articulation in the pelvis. We have sacroiliac joint 2 between the ilium of the hip bone and the sacrum. We have the sacrococcygeal symphysis between the sacrum and the coccyx. And we have the pubic symphysis between what? The pubis bodies of the two hip bones. Okay, and you know all the ligaments that attach to the lateral border of the sacrum also help what? To the stability of the bony pelvis. The function of the pelvis, first of all, to transfer of the weight from the upper exoskeleton to the lower appendicular component of the skeleton, especially during the movement, provide attachment for the muscles and the ligament that used in the locomotion, and contains and protect the abdominopelvic and the pelvic viscera. So for the pelvis, you have to know we have false pelvis and we have true pelvis. What's the meaning of the false and the true? The false pelvis, here, this one, the red area, located more superiorly. This one provides support to the lower abdominal viscera, which is what? Ilium and the sigmoid colon. So this part is not related to the obstetric. That's why we call it false pelvis, or we call it the greater pelvis. While the lesser pelvis here, the blue area, or the true pelvis, this one located inferiorly, and in this part all the pelvic cavity and the pelvic viscera are located. That's why we call this part are the true pelvis. This one that's related even to the childbirth. When we do the measurement, this is the most important for the ONG specialist, not the false pelvis. So the junction between the greater and the lesser pelvis, we call it what? The pelvic inlet. Here, this ring. The outer bony part of this pelvic inlet, we call it what? The pelvic brim. Okay? So the borders, now we have to know the borders of the pelvic inlet. Posteriorly, if you still remember, I said we have what? Sacral promontory and the wings of the sacrum. In the lateral, we have the arcuate line on the inner surface of the ilium, and the pectinal line on the superior pubic ramus. Anteriorly, it is what? The pubic symphysis. This is the borders of the pelvic inlet. We have to know pelvic inlet is very important and determines what? The size and the shape of the birth canal. Because the difference of the measurement, of course, will be decide whether this female or this woman will have normal delivery or we need to send for the cesarean or the C-section. Okay? Of course, with the help of the muscles and the ligament, well, of course, the this diameter will be changed, but mostly this pelvic inlet is the first decision that we determine how is this lady will have the delivery, normal or have cesarean. The pelvic outlet, okay, this one located at the end of the lesser pelvis. Here, you still remember this one? Okay, this is the coronal section of the pelvis. This is the pelvic inlet. Here, this is the pelvic outlet, the end. Like you have a canal, we have at the top inlet, at the end it is the outlet. So the outlet here located at the end of the lesser pelvis. Here, this is the inferior view of the pelvis. So the borders of the outlet posteriorly will be what? The tip of the coccyx. Laterally, we have the ischial tuberosities and the inferior margins of the sacrotuberous ligament. Anteriorly, we will have what? The pubic arch. Here, this is what? The pubic arch. Okay. Below this, the pubic arch, we have what? Subpubic angle. This angle also would be later, it is, of course, it is wider in female to allow the passage of the baby during what? The childbirth. While in male, it is what? Much narrower. Okay. Now we go to the types of the pelvis. We have 4 types. Gynecoid, platypeloid, android, and what? Anthropoid. This is only the 4 what? main types of the pelvis. The gynecoid, the first one, here, this one. This is have a round brim. Means we talk about the pelvic inlet when they say it, round brim. Okay. This type of the pelvis allow the passage of the average size baby with less amount of the trauma to the mother and the baby in the normal circumstances, means when the baby in the anterior position, not in the transverse, or we call it bridge position. You know the meaning of bridge position? What's the meaning of bridge?
Again,
When I say the
bridge.
baby in fixed position or transverse or anterior position.
because
Yeah.
the legs is abnormal position of the baby.
Okay, let me show you so you can understand. Okay, this one. In this slide, you can notice here, this is the anterior position. This is the normal position of the baby. The head should be down, okay, facing the vagina or the cervix. The back of the baby should be at the in front, and this is, we call it anterior. The bridge, see what is the difference between the bridge and the anterior? The leg is the first. This is, of course, the most dangerous position, and the ONG mostly prefer to do what? Cesarean section of the patient, of the baby in this position. Mostly we go for the bridge because the baby may be suffocated because the head, the body will be go out and the head will be still inside. Sometimes the head is very big, especially if the pelvis is like android or the what? Oval or the anthropoid. So difficult, so the baby will be there. So in this case, the directly doctor will prefer to go with the what? Cesarean section. And also we have this position also, this is considered abnormal or have high risk when there is the transverse what position? The baby, the transverse. It's so difficult to deliver normal in the baby in this what position. That's why with the baby like in this position at the beginning of the last month, we advise the woman to sleep on one side, to the right. So if the head, for example, to the right side, so we advise her to sleep on the right side for all this until the end of the month, so the baby may be moved. So we go to the anterior position. Otherwise, if not, if it doesn't move, of course we'll go to the cesarean. Anyway, we're not talk about this ONG. This one will be more details given by Prof. Hamida and Prof. Dr. Khaled. They will give you more details about introduction about the ONG. Okay, for the type of the pelvis, you have to know. So here, the pelvic cavity in the gynecoid, it is shallow and what have straight what side walls. The ischial spine, as you notice here, it is what? Mostly not prominence. Why? to not cause any problems to the baby when the baby moves through the pelvic cavity or the pelvic canal. The sacrum here also, it is shorter and what? More curved to give more space, to become more wider, so easy to pass for the what? The baby during the delivery. So this is considered as the best pelvic type for the ONG. So in this type of the pelvis, mostly the woman will have what? Normal delivery with no trauma to the mother or to the baby. The second type of the pelvis, we have the enteroid, here this one, from the, what you notice here, it is heart-shaped brim, not like the round. Narrow, quite narrow from the anterior. Mostly this type of the enteroid found in the tall women and the African women. They have this type of the pelvis. And of course, in the male, it's the type of the pelvis in the male, it is android. Okay? The pelvic cavity here, it is narrow and straight and long, not like the round, very short and wider. And the ischial spine, you notice here, much more prominent than in the what? Gynecoid pelvis. The third one, which is the anthropoid, here this one, the brim, it is oval, the pelvic cavity is slightly narrow, the outlet, pelvic outlet is larger. That's why in the baby, that's why in this case, in this type of the pelvis, if the baby in the anterior position, the delivery will be what? Easy, smooth, will go what? Smoothly. Nothing will happen. But if the baby in the other positions with this type of the pelvis, for sure the baby will not cross. Okay? The last type of the pelvis, we have the platyploid. This type of the pelvis, it is have kidney-shaped brim. The pelvic cavity also shallow. The anterior, posterior diameter here, it is very narrow. You can notice totally different than the round or the gynecoid. The outlet here is very wide or roomy. During the labor also, they will have some difficulty to enter what? The pelvis. You see, because the outlet is very kidney shaped. How the baby head will pass through this kidney shape? But in case the baby size sometimes only will be passed if the baby size is smaller, the head is small, for example, less than 2 kg, maybe can pass. But if it is more, 3 above, for sure will not pass from this type of the what? Pelvis. So again here we can notice about the X-ray here. This is the male pelvis and here the female what? Pelvis. You can notice the difference from the pelvic inlet, from the sacrum, you can notice here, shallow and more curved. Here, longer, straight. The pubic angle here, it is very wider in female, narrow in the male. The ischial prominence here, it is less prominent, while in the male, it is what? More prominence. Round shape, here heart shape. Okay. So this type of the comparison is very important. 6 difference of the pelvis.
Doctor,
Yes,
you
How?
approve Uyun back.
you go back.
No,
Okay.
approve Uyun back.
Well, again, Akil, what did you say?
Approve Uyun. Okay, done.
Okay now?
Yes.
Okay. So the difference here between the male and the female pelvis, the false pelvis here in the female, it is much shallow, while in the male it is deeper. The pelvic inlet in the female, it is oval or the round, while in the male it is heart-shaped. The pelvic cavity is much roomier in female than the male. The distance between the inlet and the outlet is shorter in female, while it is longer and narrower in male. The pelvic outlet is larger in female, see, larger than in the male. The sacrum, as I said, it is shorter and wider and flatter in female than in male. The sub-pubic angle or the pubic arch is much rounded in wider in the female, while in the male it is triangular and much narrower. This important, very important. Sometimes I will give you X-ray, for example, in the OSP. Will ask you what is, for example, is it for female or male? By just looking to the X-ray, you have to know this pelvis is related to male or female. It's very easy to distinguish between them. If you don't know, that would be a big problem. Okay, and later I can ask you, give me the difference. What is the characteristic, for example, if it is female, okay, give me the characteristics of the pelvis that you already answer or choose. If it is male, also give me what is for the male. Either in the end of semester or sometimes in the professional exam. I can give like this question. Anyway, for the lesser pelvis, as you know, this is very important to what? For the passage of the fetus during the childbirth. The diameter of this canal can be determined by two ways, either by the pelvic examination or through the radiograph. This pelvic examination, there is many ways. This being actually, you can give more details by clinical doctors, Prof. Hamida, I think, because she is gynecology. So you can ask her about if you want to know, because this part, it will be more complicated if I explain, even for me, because this is more related to the clinical part. So you can ask her how to do this. Maybe she can give you an introduction about the pelvic examination, how they measure the pelvic and how they know this woman will have normal or need to transfer to cesarean. Okay, so for you, just as a basic, you have to know there's two ways. How? This is you know for the clinical or by the next year. For the nerves that pass in the pelvis, we have three that supply the pelvic girdle. We have sacral plexus, coccygeal plexus, and the what? Pelvic autonomic nerves. The sacral plexus consists or composed of the fourth and the fifth lumbar spinal nerve and all what? The sacral nerves from the first to the fourth sacral nerve. This is forming all these nerves, they will forming what? Sacral plexus. Okay? This sacral plexus will innervate what? The posterior what? Pelvic wall that is located anterior to the piriformis muscle. Okay? This sacral will run from the or located anterior to the piriformis muscle along the posterior pelvic wall. The branches from the sacral plexus, we have branches that supply the lower limb, and we have branches that supply what? The pelvis. The lower limb, we have sciatic nerve, superior and inferior gluteal nerves, nerves that supply the quadratus femoris, obturator internus muscles, and what we have? Perforating cutaneous nerve and posterior femoral cutaneous nerve. This is branches that supply the lower limb that come from the sacral what? Plexus. The most important for us, that branch that supply the pelvis or the pelvic organ. We have the nerves that supply piriformis muscle. Okay. We have the pelvic splanchnic nerve, which is the provide the parasympathetic innervation to the pelvic organ. And the most important, we have the pudendal nerve that come or rise from these plexus and innervate what? The muscles and the skin of the perineum. We will take perineum later. The coccygeal plexus, which is formed by the fourth and the fifth what? Sacral spinal nerve plus what? The coccygeal nerves. Okay? This type of the plexus will supply what? The coccygeus and the levator ani muscles, being the muscles of the pelvic floor, and they will supply what? The sacrococcygeal what? Joint. The also will innervate what? The skin between the coccyx and the what? And the anus. By which nerve? Anococcygeal nerve, which is come from the coccygeal plexus. While the autonomic or the pelvic autonomic nerves, of course, we have the sacral sympathetic trunk. This one will come from the lumbar sympathetic trunk. Okay, will run in front the sacrum and behind what? The rectum. This, of course, will provide the sympathetic innervation to the pelvic organ, while the pelvic splanchnic nerve, I already explained, will provide what? The parasympathetic innervation to the pelvis. And they will join what? The hypogastric nerve to forming what? Inferior hypogastric plexus. Here, this is a pelvic splanchnic nerve. Come from the sacral number 2, 3, and 4. Okay? So this pelvic splanchnic or the autonomic we have superior, as I said, we have from the pelvic splanchnic they will forming superior and the inferior hypogastric plexus. The superior will be located in front the sacral promontory. Okay, this type of the plexus contains what? Sympathetic fiber that arise from the aortic plexus and will descend to the pelvis and divide to the left and right hypogastric nerves. While the inferior hypogastric plexus, here, this is the superior here. So you come from the aortic plexus. And they will descend as a right and left what? To the right and the left. Said lateral to the rectum. While the inferior here, the inferior hypogastric located now at the side of the rectum and at the base of the bladder and the vagina. This type will formed by the plexus of the hypogastric and what? The parasympathetic fiber of the pelvic splanchnic nerve. Clear? Inferior combination of the parasympathetic, the splanchnic nerve and the hypogastric nerve, while the superior come from the aortic plexus and they divide to supply what? The pelvis. Clear about the innervation of the or the nerves of the pelvis. We have sacral plexus, coccygeal plexus, and the autonomic. Autonomic we have sympathetic and the pelvic splanchnic, which is the parasympathetic. Because you will hear these nerves when you go through the organs. Because each part, they will, when I say pelvic splanchnic, you have to know we talk about the parasympathetic. If I say epidendal nerve, from where comes epidendal nerve? From the sacral plexus. So the arteries of the pelvis, of course, they come from the common iliac artery. Okay, this one. We have, of course, at the right and the left. They will divide each common at the both sides, but at the right they will divide to the external and the what? Internal iliac artery. External, as you know, it will go to supply, to become femoral and supply the lower limb. So this one not related to the pelvis. The internal one, this one considered as the artery of the true pelvis. Internal, this one will be also divided to the posterior and the what? Anterior trunks. So the branches from the anterior trunk, we have obturator artery, umbilical artery, inferior vesical artery, vaginal artery in the female, uterine artery in the female, and what? The middle rectal artery. This is all branches from the anterior trunk of the internal iliac artery. Of course, each one supplies different parts of the pelvic organ. For example, we have the umbilical artery that supplies superior part of the urinary bladder. But during the gestation or the baby still in the uterus, this artery is the transport the deoxygenated blood from the fetus to the placenta, if you still remember the circulation of the embryo. Okay? While the inferior vesical artery, for example, they supply what? The lower part of the bladder. In the females and the males, also they will supply the prostatic gland and the what? Seminal vesicles. For of course, in the female, the vaginal artery, they will supply, of course, the vagina, and additional to the also the inferior part of the urinary bladder and the rectum. The uterine artery will supply ovary, the uterus, the vagina, and the fallopian tube and the round ligament of the uterus. And the last one, the middle rectal artery, if you still remember, we take during the GIT, supply what? The distal part of the rectum. Oh, we still have to, okay. The last two branches of the anterior trunk, we have the internal what? Pudendal artery here, this one. This is the main artery that supply to the perineum, which is the represent the genitalia and the anus in the male or the female. Okay? And the last branch, which is the inferior gluteal artery that supply what? The gluteal muscles and the hip joints. The branches of the posterior trunk, we will have ilio-lumbar artery. Okay? This one, they will divide into lumbar branch and what? Iliac branch. The lumbar branch will supply psoas major, quadratus lumborum, and what? All the posterior abdominal muscles, while the iliac branch will supply the muscles of the bone that is around the iliac fossa. Okay? The other arteries, we have the lateral sacral arteries and the what? Superior gluteal artery. Okay, these last two branches, the sacral will supply the sacral Okay. We almost finished this part, and we go to the second lecture. Okay. So we continue stop at the branches of the posterior trunk of the internal iliac artery. We have three branches: ilio-lumbar artery, lateral sacral arteries, and the what? Superior lateral gluteal artery. The sacral arteries, we already say, supply what? The structures in the sacral canal and all the muscles of the that attach to the posterior to the sacrum. Superior gluteal arteries supply all the muscles and the skin of the gluteal regions. Clear about the artery of the pelvis? We have from the common iliac, on both sides, of course, you have right and the left. On the right, they will also divide to two, internal and external. External will supply the lower limb. This one not related to the pelvis. The most important is the internal. The internal will also divide into anterior and posterior trunk, and you have to know the branch of each trunk. Okay. There is also minor arteries of the pelvis that not come from the iliac artery or the internal iliac artery. We have the gonadal arteries. This artery, or we call it ovarian artery, in the females, arise from the what? Abdominal aorta. And they will divide to forming give branches to the ovarian and to the what? Fallopian tube. This is additional, extra to the also to the what is it? Uterine artery. Okay. Also, we have other artery that supply the organs in the pelvis, which is the median sacral artery. Okay, then in the middle of the sacrum, and also we have what? Superior rectal artery that supply the superior part of the rectum. Okay. The venous drainage also of the pelvis will follow the same like the arteries. Will be union of the common iliac vein will be formed by the union of the external and the what? Internal iliac veins. Okay. These veins, they will receive from the internal, they will receive also additional venous drainage from the ilio-lumbar vein and also from the what? Middle sacral veins. These both, the left and the right common iliac vein, they will combine at the level of the L5 to become what? The inferior vena cava and drain to the systemic circulation. Okay. For the external, as I said, external iliac vein, it is continuation of the femoral vein. So this is not related to the pelvis. Internal iliac vein, this is the responsible for the majority of the pelvic venous drainage, with the exception only from the iliolumbar vein that drain to the common iliac. Remember the iliolumbar drain to the directly to the common iliac vein, not drain to the internal. Okay. Okay. The internal also iliac vein receive blood from the superior and inferior gluteal veins, and of course receive from the internal what pudendal vein that drain all the reproductive organs and the part of the rectum. Okay, we talk about the internal iliac vein receive from these two, while all the iliolumbar they will drain directly to the common iliac vein, not to the internal. Okay, the same like as I said, artery, the branches of the internal iliac vein, the anterior trunk, the same also we found in the venous drainage. We have traitor vein, lateral sacral vein, middle rectal vein, vesical vein, and also what? Uterine and the vaginal veins. This is the part for the pelvic girdle and what? The pelvis. Is it clear? Because we need
Inshallah, clear.
we now go to the what? Pelvic floor and the perineum. You want to continue or you want to rest? Because we have different times. So if you want to continue, we can. If you don't want, we can take after 1 hour if you want. What do you?
Continue.
Continue, Doctor.
Okay. Since you want, okay. To rest the pelvic floor. Sure. Okay. Okay, now we go to we finish as I said, pelvic girdle and the pelvis, the type of the pelvis, the innervation that pass through the pelvic floor to the pelvis, and the blood supply and the venous drainage. So as you know, what is the pelvic viscera? Actually, it's not us only talk about the genital organs. Pelvic viscera means including the bladder, the rectum, and also we have the pelvic genital organs and what the terminal part of the urethra. This is when we mention the pelvic visceral organ. Okay, this is all organs located in the pelvic cavity. This cavity, as you know, located in the lesser part or the lesser pelvis below the pelvic brim. There is a number of the muscles that make up the walls of the cavity. The lateral walls of the pelvic wall consist of or forming by the obturator internus and the what? Piriformis muscle. This is the lateral wall of the pelvic cavity. For the pelvic floor, or we call it what? The pelvic diaphragm. Okay, this is a superior view. Here, the inferior view. It is a funnel-shaped structure, okay, attached to the walls of the lesser pelvis, which is the muscles that I already mentioned, internus, obturator, and the piriformis muscle. Okay, the perineum here. This is the perineum that located what contains the genitalia and the anus. Okay, and located below what the perineum or below the pelvic floor. Okay, so the perineum, later this one, they have important role in the functions like the maturation, defecation, for the sexual intercourse, and for the child birth. Okay. So for in the pelvic floor, it is like as I said, it is a diaphragm. These diaphragm have a gaps. Why we have a gaps? To allow for the urination and the defecation. So we have two openings in the pelvic floor. We have urogenital hiatus, and there is what? The rectal hiatus. The urogenital hiatus, this one located anteriorly, okay, allow the passage of the urethra in the male and in the female, of course, the urethra and the what? Plus the vagina. While the rectal hiatus is located at the center, okay, allow the passage of the what? The anal canal. Between these two hiatus, the urogenital and the anal hiatus, there is what? The fibrous node. Okay, this fibrous node, we call it what? Perineal body. This perineal body considered like the central point that all the support, the muscles of the pelvic floor and what? The perineum together. That's why they stay all in one unity together by the perineal body. So the function of the pelvic floor muscles for what? To support the abdominal pelvic viscera, which is the bladder, intestine, the uterus, through any their what? Tonic, when they are in the tonic contraction. Resistance to increase in the intra-pelvic pressure or the what? Intra-abdominal pressure during activities like coughing or what? Lifting heavy objects. And of course, to support what? During the urinary and what? Then the fecal continence. This muscle contains what? Have the sphincter. If you still remember, when you take the GIT or when you go through the urinary, there's a sphincter to help what? That work on the rectum and the urethra. Relaxation of this muscle allow what? The urination and what? The defecation. Okay. Now we go to the muscles that forming the pelvic floor. We have two main muscles. Okay. We have levator ani muscles, which is the largest component here. This is the levator ani muscles. And we have the coccygeus muscle. And of course, within these two muscles, we have the fascia that covering what? These muscles. All this is forming, or this is a component of the what? The pelvic floor. So we start with the levator ani muscle. It is a broad sheet of the muscle. Consists of the three separate paired muscles: pubococcygeus, puborectalis, iliococcygeus what? Muscles. We have three muscles. Levator ani muscles, it consists of three muscles, three paired muscles. These muscles innervated by the anterior ramus of the S4 and branches of the pudendal nerve. The attachment of this muscle anteriorly to the pubic bodies of the hip bone, here, you see, here. This is a puborectalis, pubococcygeus, and what? Iliococcygeus. All they attach to the pubic bodies. Laterally, they will attach to the fascia of the obturator internus muscle, the lateral wall of the pelvic cavity. This fascia, we call it what? Tendinous arch. It's become white. You know, the fascia like same like in the anterior abdominal wall, the rectus abdominis, the pectinal, what do you call it? Pectinal line? What was the line? The fibrous line that separates the rectus abdominis muscle? What do you call it? The fibrous or the fascia that separate the rectus abdominis muscle.
Linea alba.
What do you call?
Linea alba.
Ah, linea alba. Okay, correct. Okay, this fascia, it is similar to the linea bone, the extension of the muscle or the end of the muscles. They will forming what? A fascia, or we call it not a tendon, fascia, strong fascia actually, strong fascia. These fascia, they will all the muscles of the levator ani muscle will connect with this fascia. We call it tendinous arch. Posteriorly, they will attach to the what? Ischial spines of the hip bone. The puborectalis, the first muscle. Now we go in details for each muscle. The puborectalis here, the first one, the red one. Okay. This is a U-shaped muscle. Extend from the body of the pubic bone pass the urogenital hiatus around what? The anal canal. This muscle will create what? When there is contraction of this muscle will creating what? The anorectal angle and lead to bend of the anal canal anteriorly at the 90-degree and forming what? The anorectal junction. The main function of this muscle to maintain what? The fecal continence. During the defecation, this muscle should be what? Relaxed. Contractions to maintain. Relaxation, lower the defecation. There is some other fibers located within this muscle known as the what? Pre-rectal fibers. Here, this. It's not green, mostly like the green. Okay. Pre-rectal fibers. Here also they were forming another U-shaped muscle. They were surrounding what? The urethra in the male and what? Urethra and the vagina in the female. These fibers important for preserving what? Urinary continence, especially when there is increase in the intra-abdominal pressure, for example, during what? The sneezing. That's why when you sneeze, this causes increased intra-abdominal pressure. How to maintain the urinary continence? By these muscles or these fibers. We call it pre-rectal fiber. The second muscle of the levator ani muscle, which is the pubococcygeus here, this one. It is a hammock-like muscle. You know the meaning of hammock? You know, like the swing? Similar like swing, hammock-like muscle. This is the main muscle of the levator ani muscles, among the other muscles. They will arise from the also pubic bone, okay, and the anterior part of the tendinous arch, and they will what? Run posterior-medially and attach to the what? Coccyx and the anococcygeal ligament. These muscles support what? The pelvic organ. Actually, this is the main, as I said, this is the main component of the levator ani muscle, the pubococcygeus muscle. The last one, which is the iliococcygeus muscle here, the light green, it is a thin muscle fiber, starts from the ischial spine anteriorly and from the posterior of the tendinous arch, and they will insert all or posteriorly to the what? Coccyx and the anococcygeal ligament, same like the pubococcygeus muscle. This muscle actually, it is the actual levator of the three what? Levator and muscles. Their action is to elevate what? The pelvic floor and to elevate the anorectal what? Canal. Okay. We finish about the levator ani muscles. Now we go to the coccygeus here, the purple, located most posteriorly. Okay, most posterior pelvic floor component originate from the ischial spine, and they will travel to the lateral aspect. See, attached to the lateral part or the lateral border of the sacrum and the coccyx. These muscles innervated also by the anterior rami of the S4 and the S5, and also these assess the levator ani and the piriformis muscle and close the back part of the outlet or the pelvis outlet. The pelvic floor dysfunctions, when it happen, actually, you know, the pelvic floor in general, it is very important to support, as I said, what? Pelvic organs, and supporting what? The fetal head during the cervix dilatation in the childbirth. That force during the childbirth is carried by the pelvic floor, pelvic muscles. During the second phase of the childbirth, the levator ani muscles, okay, and the pudendal nerve will be at high risk of the damage, because already the head in the middle of the pelvic cavity. So the pubococcygeus and the puborectalis muscle will be what? Very high risk to injury, because these muscles are located, if you remember, puborectalis and pubococcygeus, more close to the vagina. So when there is, during the second phase, these muscles will be what? Highly risk to damage or injured. The damage to these muscles, what will happen? Lead to the urinary stress incontinence and what? Rectal incontinence. Because remember, as I said, what? They help for defecation and for the urination, right? So if these muscles become damaged, for sure will lead to the what? Urinary incontinence and rectal what? Incontinence, especially when there is what? Increase in the intra-abdominal pressure. So the prolapse of the pelvic viscera because of the pelvic floor dysfunction lead to the what? Prolapse of the pelvic viscera. We have what is the pelvic viscera that will be prolapse? Urinary bladder, vagina, and in the most severe cases, sometimes the uterus also will be prolapse. You can see the uterus outside, not inside. You should, if you go with the BONG specialist in future, you will see like these cases a lot. Anyway, so for the prolapse, this happens when there is trauma to the pelvic floor. If the muscle fiber have been torn during the childbirth, of course, the torn of the pelvic or the muscle fibers have different degree. We have the first degree when they only just involve the vaginal mucosa, only in the vagina. The second degree when they involve also the perineal muscle, see the damage, the tearing. The third degree when it involve the anal sphincter, the vagina and the perineal and the anal. The last degree, which is the most worse, when already involved with the what? Rectum. Oh, this kind of the tearing, oh, so bad. And the other thing, when there is damage, what? As I said here, to the what? Perineal body during the childbirth, this will lead to the prolapse of the vagina. Here, you can see? Sometimes here there is a vaginal prolapse, here in this case. The other one, here there is vaginal and also the rectum. Here already have uterine prolapse, the uterus outside. I saw one time, a friend, actually my ONG, Prof. Hamida, she do one time surgery for this to repair this kind of condition. Oh, it's so bad condition. The other thing, if there is what? The medial fiber of the puborectalis also will be torn within the what? Perineal body will lead to the what? Rectal herniation. All the, the stool will go through the what? Through the vagina. Because already there is what? Herniation. Because of the what? Pelvic floor dysfunction or the weakness, or there is a tool like this degree. In the rectum, already involved the rectum. We find the stool will be what? Go through the vagina. That's why I said it's the last degree, it's the worst. Clear about the prolapse of the pelvic viscera? What's the reason for the prolapse of the pelvic viscera? Because of the pelvic floor dysfunction. How this happens, pelvic floor dysfunction? Either trauma or tearing or damage to the perineal body during the childbirth, or damage or the tear for the puborectalis plus the perineal body. Perineal body here, between the vaginal orifice and the anus. So for the risk factor that can increase the chance of the prolapse, of course, the age, increase the age of the female, they have high chances to get what? The pelvic floor dysfunction or the prolapse of the pelvic viscera. The number of the vaginal deliveries, that women who have more than 15, 17 vaginal deliveries, for sure they will have pelvic floor or prolapse of the pelvic viscera. The family history of the pelvic floor dysfunction, the weight, especially when they are heavy weight, chronic coughing, and also this is the factors. The only treatment for the pelvic floor dysfunction only repaired surgically. There is no other options or medications to treat this kind of condition. But to reduce the chance for the pelvic floor dysfunction, we advise the woman to do exercise or pelvic floor exercise. We call it what? The Kegel exercise. When we do this type of the exercise, that help to what? Strengthen the pelvic muscles. Should lie down and raise the body or the trunk. This type of the exercise will, of course, will strengthen what? The pelvic muscle, and we advise the woman to do, especially after what? The delivery, vaginal delivery. Vaginal delivery means the normal delivery. We don't talk about the cesarean. Cesarean means she not go through the vaginal delivery. Okay? The other thing also to reduce the damage or the tear of the pelvic floor is to do what? Kind of the surgery or the surgical cut in the perineum known as the epistomy. This epistomy, the surgeon do it, especially when there is the first baby. The dilatation will be sometimes okay, normal, but the perineum or the opening in the perineum, the baby pass during the childbirth will cause what? Tearing to the perineum. If we not do this kind of the surgical cut in the perineum, the tearing will be from lateral, posterior, anterior, so bad, so difficult to do stitch later. So to avoid this, we better do surgical cut. So easy for us what? To control the tearing of the what? Perineal muscles, and the healing will be faster. But if you just leave it, the tearing, like you have a tube, for example, when you like have a straw, and you want to pass the apple within this straw, what will happen to the straw? For sure will be tearing from every direction, same like in the vagina. In the baby pass, if you not do this type of the surgical cut, the tearing will be so bad. And you have to know the vagina and the uterus are very, vascular parts. So the bleeding there, it's too difficult to stop. A lot of blood supply to this part. So when there's bleeding, sometimes women may die because of the what? Tearing in the perineal or the pelvic floor. So we go to the last part to finish about the, what is it? Pelvic floor. Now we go to the perineum. Below the pelvic floor, we have what? The perineum. Okay. This located between the thigh and represent the most inferior part of the what? Pelvic outlet. Okay. The perineum separated from the pelvic cavity superiorly by the what? Pelvic floor that we already just finished talk about it. This region contains all the structures that support the urogenital and what? Gastrointestinal systems. Have important role or functions in the micturition, defecation, sexual intercourse, and for the what? Childbirth. The boundaries for the perineum, actually we use this, if you go for the clinical, perineum means we talk about the external genitalia and the anus. We don't say external genitalia, we just say perineum. When I say perineum, I know what you're talking about, or where is the area that you're talking about. So the perineum, actually, it is diamond-shaped structures. The anatomical border for the perineum, anteriorly, it is the pubic symphysis. Posterior tip of the coccyx, laterally it is the inferior pubic rami and what? Inferior ischial rami and the sacrotuberous ligament. The roof of the perineum, it is the pelvic floor, and the base or the inferior part would be the what? Skin and the fascia. The surface of the perineum, anteriorly in the females, it is the mons pubis, while in the males it is what? The base of the penis. Laterally there is what? The medial surface of the thigh. Posteriorly will be what? The superior end of the intergluteal cleft. So be careful when I say anatomical border, when I ask about the what? Surface border. Please be careful. This term is important. So the boundaries, the perineum, we divided, I already said, it is what? Diamond shape. So this diamond shape we divided by the transverse theoretical line. Okay, this line extends between the two ischial what? Tuberosities. Because of this line, we divided the perineum into two triangular. We have anterior urogenital triangular and we have what? Anal triangular. Okay. So the anal triangular located what? More posterior, or the posterior half of the perineum, is bounded by the coccyx, sacrotuberous ligament, and what? The theoretical line between the ischial tuberosities. The main content of the anal triangular will be what? The anal aperture, which is the opening of the anus, and consists of the what? External anal sphincter muscle, which is the voluntary muscle that's responsible for opening and closing of the anus. Also have the SQ anal fossa at the both sides. Remember, this is spaces that help what? Or allow the expansion of the anal canal during what? The defecation. Okay, and of course in this area the anal triangular have the pudendal nerve that supply the whole perineum with the what? Somatic fiber. While the urogenital triangular, okay, this is the anterior part, half of the perineum, bounded by the pubic symphysis, SQ pubic rami, and the what? The theoretical line, here this one, between the ischial what? Tuberosities. These triangular, from the name, is associated with the urogenital system, which is the external genitalia and the urethra. This triangular actually different from the anal triangular because have additional what? Strong deep fascia. We call it what? Perineal membrane. We have to know above this perineal membrane, we have different pouch above and below what? This perineal membrane, and what the structures should be found in each pouch. So we start from the deep to the superficial in the urogenital triangular. From the deep, we have the first one, the purple, the deep perineal pouch. This pouch located between the pelvic floor and the perineal membrane, here the red line. This type or this space contains part of the urethra, external urethral sphincter, and the vagina in female. In males, they contains the bulbourethral glands and the deep what? Transverse perineal muscles. Later you will know in details all these structures. We go for each, what is it? For male or the female. The second layer here, in the urogenital, we have, this is the perineal membrane. This is what we talk about. In the inner triangular, this perineal membrane is not there. Only in the urogenital triangle. So this one is the tough layer of the tough fascia perforated by the urethra in the male and urethra in the vagina in the female. The main function of this membrane to provide attachment for the muscles of the external genitalia. Below the perineal membrane, we have the superficial what? Perineal pouch here, the yellow part, the yellow area. This space contains what? The erectile tissue that form the penis in the male and the clitoris what? In the female. And also contain what? The three muscles, which is the ischocavernosus, bulbus spongiosus, and the superficial transverse perineal muscles. The first two muscles actually in the male, if not remember, if I'm not mistaken, they help for empty what? The urinary penile, the urinary during what? The penile, the urethra and the penis during the urination and what? The ejaculations. While in the female, these two muscles help for the empty the secretions from the Bartholine glands. These glands are important for the lubrications of the vagina during the sexual intercourse. So These two muscles are found in both sex, but both muscles have different functions in the male or in the female. And also in this pouch have also the greater vestibular gland, which is the Bartholin's glands, as I already talked about, help for the lubrication of the vulva and the vagina in the female during the sexual intercourse. Below this layer, the yellow one, superficial perineal pouch, we have the perineal fascia. Okay, this one. This is a continuation of the abdominal fascia, which consists of two layers, the deep and superficial. The deep would cover the superficial perineal muscles and all the protruding structures, penis and the clitoris in the female. While the superficial will be divided into two other layers, which is superficial and also deep. The superficial would be, it is a continuous with the Camper's fascia of the anterior abdominal wall. Remember the Camper's fascia when we talk about the fascia and the abdominal wall. While the deep layer, it is continuous with the Scarpus fascia also of the anterior abdominal wall. If you want to remember, go to the lecture of the abdominal wall, study about the fascia again. So this is continuation of the abdominal fascia, this layer, perineal fascia. At the end of this urogenital triangular, we have the skin, which contains the urethral and the vaginal orifice that open into the skin. The last part of the perineum I talk about, it is the perineal body here, the yellow part. This is the regular fibromuscular mass located at the junction of the urogenital and anal triangular. Here, this is the anal, here the urogenital. It is the center point of the perineum, contains this perineal body, skeletal muscle, smooth muscle, and collagenous and the elastic fibers. This perineal body gives the point of attachment for a lot of the muscles on the pelvic floor and also the perineum. What is these structures? Levator ani muscles, bulbous majorsis muscle, superficial and the deep transverse perineal muscles, and external anal sphincter and external urethral sphincter muscle. That's why perineal body, if there is damage in the perineal body, for sure they will have the female, they will face mostly pelvic floor dysfunction and later prolapse of the pelvic organ. Okay, in the male, the perineal body located between this is the perineal body between the bulb of the penis and the anus, while in the female it is located between the vagina and the external anal sphincter. This perineal body supporting the posterior part of the vaginal wall against the prolapse. That's why I said perineal body is very, very, very important. And during the childbirth, the ONG or doctor try to not cause damage to these parts. The neurovascular supply for the perineal body, for the perineum, as I said, it is come from the pudendal nerve, while the artery comes from the internal pudendal artery, which is come from the internal pudendal internal iliac artery from the anterior trunk. Yes, anterior trunk. Okay. While the pudendal, this neurovascular, the nerve and the artery, they will pass through the SQ anal fossa. Remember SQ anal fossa at the both sides of the anal canal? These, they will come through these fossa and supply all give the branches to the anal and the genital triangles. The last thing, okay, we finish. Just most of the common conditions in the seen in the perineum. We will go later. We will go in the female reproductive system, known as the Bartholinitis. Bartholinitis means infection or inflammation of the major vestibular glands, or we call it Bartholin glands. As I said, these glands are important for the lubrication of the vagina and the vulva. So these glands found normally, it is of course not visible, not remarkable. So located at the lower third of the labia majora. Okay. The most common cause of this infection is the Staphylococcus or the what? E. coli. This bacteria, most common. So in case of there is infected or the duct being blocked, will lead to the swelling of the gland and filled with the fluid. Okay? Okay. Of course, in this case, we will give antibiotic and sometimes we need to do drainage to what? Treat this kind of the conditions. Okay, that's all. Any question? Because time will be almost finished. Any question?
The question.
No from me, doctor.
Okay.